A HIV infected person presents with jaundice. His ERCP is being shown. What do you see in this? You are seeing a beaded appearance, which is sign of sclerosing cholangitis. And you have taken histology. This is a typical histology of a bile duct with sclerosing cholangitis. Now in HIV patients, which organism lead to sclerosing cholangitis? Indirectly puch rahe. So Cryptosporidium is known to lead to sclerosing cholangitis is what you have to basically remember. 26-year-old is having mitral valve prolapse and developed a fever after a dental procedure. Her urine contains red cells, and rheumatoid factor is elevated, and her renal biopsy is being shown. Basically, doctor, in an image based exam, you must know how to appreciate FSGS, focal segment glomerulosclerosis, membranous nephropathy, membranous proliferative glomerulonephritis. Proliferative will have a tram track like appearance. Tram track, a double contoured track you are seeing, no? Just like you are going in aeroplane and you see in the ground the roads, how do they look like? Tram track. It is a membranous proliferative glomerulonephritis. Membranous proliferative glomerulonephritis is an immune complex deposit scenario. So one of the risk factors for it is infective endocarditis in the backdrop of MVP. That is the reason MVP patient developed fever means infective endocarditis. And histology is showing MPGN. So we are asking what is the pathophysiology of MPGN. It is an immune complex disorder, hence there is a low serum complement levels is what you have to basically appreciate. A 55-year-old, temperature is 39.3 and HbA1c is 8.7%. Urine shows numerous WBCs and a coronary reconstructed image is being shown. What do you see in this? The pathology lies with the papillae. Backdrop of diabetes, which is a poorly controlled diabetes, presenting with UTI, with WBCs in the urine. Classically is the problem of papillary necrosis, and the gross appearance also shows the presence of the scarred tissue in the renal papillae. This is all the scarring which you can see in the renal papillae. So what is the pathology that you are seeing is the question. It is a case of papillary necrosis is what you have to basically appreciate. Then a 22-year-old has come with a diffuse erythematous rash nearly all of his body, and he is also having irritability, vomiting, constipation, polyuria, and ECG is being shown. What do you see in this ECG? Fundamentally, there is a problem in the QT. See, this is the QRS complex, then you have a T wave. Between Q and T, the distance is very narrow. That is called shortening of the QT interval. Shortening of the QT interval is the classical feature of which dyslipidemia? Hypercalcemia. You can expect in DNB, All India, State PG, all online based exams, at least 2 or 3 ECGs will definitely be asked, and one of them will be definitely from the dyslipidemias, hypercalcemia, hypocalcemia, etc., etc. A color Doppler is being shown. Patient is having a family history of sudden cardiac death. Sudden cardiac death is a feature of only 2 conditions. What are they? One is mitral valve prolapse, second is hypertrophic obstructive cardiomyopathy. 18 topics, doctor, cardiology. You will hardly take 10 hours to revise. We have in the cardiology online video library, in the internal medicine, in the general medicine, if you go to anatomy2medicine.com, you have got a general medicine, in that cardiology, in that 10 hours, 18 topics. If you focus, at least listen once, you can read it fast, another 2-3 hours, and that's all the end. So 50 to 60 hours general medicine will be done. You should not read more than that. Overall you should not read more than 300 hours. If you read more than 300 hours means you are wasting time. 1100 topics, 300 hours. Like a businessman finishing his job on a business trip. You have to go for an academic trip. Finish the business and get back. Life is more beautiful. Not always reading and wasting life. Right? So what do you have here? Interventricular septum, which is hypertrophy. From this called axial view, where you are able to have long parasternal axial view, where left atrium to blood will go into left ventricle. This is left atrium, doctor, into this is the mitral valve. Through that the blood will go into left ventricle. From left ventricle it will go up into aorta. And what do you have here? Aortic valve. And the mitral valve's anterior leaflet and the interventricular septum, which is hypertrophy, will come and touch each other. If they touch each other during this mitral valve leaflet and interventricular septum, they touch each other, the left ventricular blood cannot flow freely into aorta. And that is the whole problem in the patients who are having hypertrophy. Obstructive cardiomyopathy is what need to be remembered. So what do you have in this condition? You have got, all these are true, but the murmur will increase, not decrease with Valsalva maneuver. Why the murmur increase with the Valsalva maneuver? Let us see. No, don't go into whiteboard, but focus on the board. Yeah. See, fundamentally in HOCM what is happening? Interventricular septum and the mitral valve leaflet are touching each other. So the blood which is flowing from left atrium into left ventricle has to go up into aorta. Okay. So that blood flow is being stopped by the touching of these two. If the ventricle volume is less, smaller, will the touching will be more or less? More. So what makes the ventricular volume to decrease? Let us say you are having inspiration. Inspiration will cause negative intrathoracic pressure. Negative intrathoracic pressure sucks the blood into heart. So if more blood comes into heart, what happens to ventricle size? Increases, and the touching will decrease. So inspiration decreases the obstruction. You agree? Inspiration sucks the blood into heart, increase the ventricular size, decrease touching, and increase the flow and decrease the obstruction. Agree? Opposite to inspiration is called Valsalva maneuver. What is Valsalva maneuver? Whenever you take expiration against a closed glottis, closed glottis, then it is opposite to inspiration. Expiration against a closed glottis will produce positive pressure, which will cause collapse of veins and decrease venous return to heart. Whereas inspiration, negative intrathoracic pressure sucks the blood and pumps into heart. So inspiration will decrease obstruction of HOCM because more blood will come to heart. Expiration will cause less blood to heart, ventricle chambers has become small, and touching will be more, obstruction will be more. That is what you need to basically appreciate. So systolic ejection murmur will increase with Valsalva, not decrease in HOCM. 64-year-old is having a interscapular pain, which is suggestive of aortic dissection. Is this dissection is involving ascending aorta or only it is involving descending aorta? In this in this MR picture, you are able to see broadening of the descending aorta. No, doctor, normal caliber is this much, but this is broadening, but ascending aorta is normal in caliber, only descending aorta it is involved. So any aortic aneurysm which involves only the ascending plus part of distal aorta, you call it as type 1. The one which is only involving ascending aorta is called type 2. Type 3 means distal aorta. Okay. So that is type 1, 2, 3 type of classification. But what is type A and B type of classification? That is called Stanford classification. Descending aorta is called type B. Don't confuse it with DBAC is type 2. Type 2 is DBAC is ascending aorta, but type B Stanford is descending aorta. So what you have here is only what type? Descending aorta involving one. So whenever it does not involve ascending aorta, it will not involve aortic valve. It will not lead to any aortic regurgitation. So you need not surgically repair the valve. If it is not involving ascending aorta, if it is only involving descending aorta, then what type of Stanford you call it as? Just now we said no, type B. Whenever type B is there, only descending aorta, ascending aorta is not involved. If it is not involved, aortic valve is not involved, aortic regurgitation is not there. You don't need to do surgically repair, only you need to do the blood pressure management and prevent further dissection of aorta. Whereas if it is involving ascending aorta also, what type you call Stanford? Type A. Then you will have aortic valve dilated and regurgitation will be severe. Hence you need to do surgical treatment. So Stanford type A require medical plus surgical management and type B require, come on, require, you should sync with my speed, then only you will catch. There is nothing confusing, simple thing, doctor. जरा बोर्ड दे दो. Problem is, we will come to a fixed opinion that some things we can't understand, we can't read, they are not for us kind of a thing. In our days also, gynecology obstetrics means, oh, that is not our thing, only general medicine, every time Harjan. But stupid, it's a pond of stupidity to think like that. If you really attend 15 days seriously labor room posting, entire obstetrics looks like Harrison. So first take away from the mind that maybe I can't understand this kind of a thing. Once you get that feeling, you can never. If you start feeling, oh, it's me only, no one else. If I can't understand, entire class will not understand. If you come into the killing spirit, then you will start performing and achieving. Okay, doctor? Chalo, let me tell you. Simple, doctor. Heart is there, na? From the left ventricle, a tube is coming, na? What is that tube called? Aorta. Aorta has got aortic valve, na? Then it becomes arch of aorta and descending aorta. When do you call type A? If it is involving, dissection is involving ascending aorta, and also if it is involving descending aorta, you call type A. Type B means only descending aorta. If the type B is involved, right, you only need to control the blood pressure and prevent that tearing force, right? But if type A is there, then you also need to repair the aortic valve because of the dissection it got dilated and regurgitation is happening, right? You need to repair the aortic valve also. So surgery plus medicine is the treatment of type A, and only medical is the treatment of. I think board is needed, huh? So that without board, in air if we do, it will be only a Sarkar magic show. Lot of teachers don't, even I would never used to use the board, but earlier days only I used to teach. Now lot of teachers, we have almost 143 faculty. Right now about 8 locations teachers are teaching. They've flown from different areas. They may be teaching the same lesson in a live class to the students. So after seeing them, I understood on whiteboard we teaching, people understand better. Even patient also sometimes on paper you draw and explain. He will agree, okay, I'll get operated. In air if you can't do, or if you flip a few PowerPoint slides, he won't agree. Right? So that is the whole problem.